Dr. Sonu, for including me in this wonderful program, and also very important instruction course. I think a lot of people are started doing these phakic surgeries. I think most of my points, I think Dr. Kamal might have been already spoken. I don't have much job to do that. So, as he already said, that posterior chamber intraocular lens implantation is a technique to correct a very high myopia. However, the number of ICL has been, even now people are started implanting in the low and moderate myopia too. With the increased surgical number, the possible complication also can go up. But one important thing, the central hole in the phakic IOL was a significant improvement in the design. Always I started my phakic IOL practice almost 15 years back. That time we did not have a central hole. The chances of increasing in the intraocular pressure also, cataract formation was much higher, but probably the greatest innovation goes to this central hole. But complications do happen with any of the surgery. But the most common one in this phakic lens is none other than the vault. So what exactly is the vault? It is the space between the posterior surface of the phakic lens and the anterior surface of the human crystalline lens. So what should be the ideal size phakic IOL which provide a vault within a range of 250 to 750 micron? That means, in other sense, to tell that half a corneal thickness to 1.5 corneal thickness. So when we call it is as an undersized lens, when the vault is less than 125 micron, so in such cases, definitely there is an increased risk of patient may develop anterior subcapsular opacification. So when we call it is an oversized lens, when the vault is more than 1000 micron. So what will happen if you have got a high vault, it may push the iris forward and chances of becoming close angles and chances of increasing the intraocular pressure and also iris malfunction. There are different methods to measure the vault. Normally it is measured by anti-segment OCT, and you can even measure by the slit lamp manually also. So always, as Kamal said, that it is directly correlated to the size of the phakic IOL. Undersized phakic IOL that causes low vault, you have to remember. Oversized IOL causes high vault. So once again, I think already been explained in very, very important is white to white, its relationship with the vault. So you can see here there is a normal vault post-operatively. So you can see here patient with a normal vault with a very high vault, which can causing a pupillary block and an increased risk of angle closure glaucoma. See here you can see a vault of around 793 micron. So here you can see the anter-segment showing the low vault postoperatively, causing a risk of subcapsular opacification. So it is almost touching the anterocapsule. So this is a few of the slit lamp images to show how exactly oversized high vault can be seen. This is about the slit lamp examination of low vault. How can you see in the slit lamp? Because why I am showing you how you will see in the slit lamp about vault measurement, how you have to see in the anter-segment OCT. This is very important because once a patient comes to you all see in the slit lamp, your mind has to go whether it is high vault or normal vault. So this is the schematic image of external white to white and the internal measurement angle to angle, sulcus to sulcus distance, and the lens size relevant for sizing of phakic IOL. This is very, very, very important. So there are different tools available in the market. Once again, I am touching here about to measure the white to white. I think the older version of Orb scan used to give a fantastic results. Pentacam gives IOL Master 700, lens star, Sirius, OPD scan by NIDEC also, optical biometry, but most of us, I think, depend upon this digital calipers. See, this is how AIOC gives. Normally, those who are well versed to the AIOC, they can first do the AIOC, write down the reading. If you are having IOL Master 500 or 700 also, it gives the white to white. OPD scan also give quite accurate white to white. See, but very important to show how you do with the digital calipers. You have to do the calibration for digital caliper. This is very, very important. A lot of people, they do monthly once case, they kept it in the box. Then when they take out these digital calipers, it may give a very wrong reading. So you have to calibrate these digital calipers. So best to do a white to white only. We used to tell, I have done last few cases with black to black. Some of my ICLs are becoming a undersized. So now once again I gone back to the white to white measurement. So these are the pearls for white to white. So white to white measurement by digital calipers, after you do, I think I take this digital calipers, put it in front of the scale, I'm double check with the measurement. So digital calipers should be done under the microscope in high resolution, measured from mid-limbus to the mid-limbus. This is very, very important. You can use OP-scan also to validate the caliper measurement. Very, very important. If you have got a IOL Master or similar device, make sure that it validates the output. Some reports of IOL Master say that 500, it gives a overestimation of white to white. Especially you should be very careful, patients with pterygium, pigmented area around the cornea. Evaluate discrepancies between measuring devices and between the eyes. Both eyes should have about same white to white. This is very, very important. Let me come to the 1 or 2 point about the ultrasound biomicroscopy with a high frequency ultrasound that provides the exact information through slit lamp microscopy anti-segment OCT. So preoperatively we used to use it for post-iris to see the post-iris anomalies. Probably this is the only one instrument which can give the actual sulcus to sulcus measurement, which could exactly ascertain the size of the phakic IOL. But to do this ultrasound biomicroscopy, you need experience. You need to do a repeated time, then only to make yourself best for that. Post-operatively, it evaluate the appropriate position of the phakic IOL of the posterior chamber, including optical zone, bilateral haptic, relation to the iris, crystalline lines, zonules, and ciliary body. This is what we see in ultrasound biomicroscopy. So, measurement of high vault, vaulting beyond management of high vault, vaulting beyond 750 micron. As I already said that there is a possibilities of glaucoma and narrowing of the angle. Suppose if you put a plane or spherical ICL, you can rotate the ICL from horizontal to the vertical position. This will lower the vault by around 200 microns. Why it is? Because always you know that vertical white to white is higher than the horizontal white to white. Then in such cases, you can repeat the gonioscopy every visit to note the development of antrasynechia. Toric phakic lens with a very high vault, more than 1000 micron, better to plan for a phakic IOL exchange. So how you manage the lower vault? If the vault lower than 250 micron, keep a watch, because I had already told because of the central hole. In toric phakic IOL, sometimes if it is a low vault, if you already implant a toric phakic IOL, the chances of rotation will be very high. As I said already before, cataract is the most common complication. So every time you have to do a dilated fundus examination, note for peripheral development of the lenticular opacity. If present, plan for explant and exchange the right sized ICL. Case reported vault as low as 120 micron can also left alone in presence of with a central hole. So in conclusion, phakic intraocular lens, especially the ICL session, which has changed the course of the refractive surgery. With the new designs and newer companies for phakic IOL, due diligence is required for vault measurement too. Vault measurement is important as can make or break the success of the surgery. Use of newer technology for diagnosing, measuring, planning of surgery helps in prevent major complication later. Very important, calibration, validation of measuring white-to-white equipment is of absolute importance. Once again, I thank Sonu for including me this wonderful IC. Thank you one and all.
Thank you, Dr. Kudlu. Very lucid, starting from basics to advanced.